Welcome everyone. In this session, we'll talk about the disorders of the nose and paranasal sinuses. So first, the granulomatous diseases of nose. First is syphilis. The important point is that the syphilis affects the bony part of the septum. Later we'll see that the tuberculosis, it affects the cartilaginous part of the septum. So first syphilis. The various stages of the syphilis, they are primary, secondary and tertiary, and the lesions of the syphilis which occur in the primary, they are known as chancres, and the nodes, they are rubbery in structure, rubbery nodes. In secondary syphilis, it is the most infectious stage of the syphilis, and the nodes here, they are shorty nodes, they are shorty in structure. The tertiary stage, the characteristic lesion of the tertiary stage is gumma. And also the deformities of the external nose occur in the tertiary stage of the nose, that is the settling of nose, the palatal perforation. These two occur very commonly. Now there is one congenital syphilis also, in which Hutchinson's teeth are seen, corneal opacities are seen, sensory neural hearing loss is seen, and interstitial keratitis is seen. So these are symptoms which are seen in congenital syphilis. Now tuberculosis, as I told you, it affects the cartilaginous septum. It is asked as an MCQ. TB affects cartilaginous, syphilis affects bony part of the septum. Lupus vulgaris, it is an indolent and chronic form of tuberculosis, may affect the nose. Characteristically, apple jelly nodules are seen. It is an MCQ. Apple jelly nodules are seen in lupus vulgaris. Not only nose, in any place. Now comes rhinoscleroma. It is a bacterial infection which is caused by Frisch bacillus, which is a gram-negative bacillus, Klebsiella rhinoscleromatis. This is the name of the bacillus. It is very often asked in MCQs. It is more common in North India. And there are three stages of the disease: the atrophic stage, the granulomatous stage, and cicatricial stage. Malignant transformation is known to occur. The characteristic Miculic cell and Russell bodies are seen in rhinoscleroma. Both these are very frequently asked in MCQs. So what are Miculic cells? They are the large foam cells with central nucleus and vacuolated cytoplasm. And Russell bodies, they have a centric nucleus with pink cytoplasm. They both are seen in rhinoscleroma histopathologically. The treatment of this disease is streptomycin, tetramycin and rifampicin in suitable doses. Now leprosy. Nose involvement more commonly occurs in the lepromatous type of leprosy rather than the tubercular type. Next disease is rhinosporiodosis. Now this disease is to be differentiated from rhinoscleroma. How? First of all, it is a fungal disease, unlike rhinoscleroma, which is bacterial. This disease is caused by Rhinosporidium sebarii. It's a fungus. Now another difference is this disease is more commonly seen in South India in contaminated pond water. So if a question is asked and contaminated pond water is given, South India is given, so it will point to rhinosporiodosis. And strawberry colored lesions which are studded with white dots, which are actually the sporangia of the fungus, they are seen in the nose. Now third disease which simulates these two diseases is rhinophyma. It is also known as the potato tumor of the nose. It is a benign disease in which there is hypertrophy of the sebaceous glands, more commonly seen in men, at the tip of the nose, also known as potato tumor. So these three diseases should be differentiated. Another fungal infection of the nose is aspergillosis, which is in fact the commonest fungal infection of the nose and the paranasal sinuses. And Aspergillus fumigatus is the most common culprit, followed by Aspergillus niger. Next we move on to another disease, which is the deviated nasal septum. Now as we can see in this diagram, the deviation can be of various types. It can be a straight deviation, which is known as crooked nose. This is S-shaped deviation. This is a septal spur, in which only a particular part has a pointed projection. This is C-shaped deviation, and this one is a thickened septum. So these are various types of septal deviations. And one important point in septal deviation is Sludger's neuralgia, also known as anterior ethmoidal nerve syndrome. Now it is a pain around the nasal bridge due to the middle turbinate pressing on the septum. Now the deviated septum, it can press the middle turbinate, which causes, in this case or in any case, it causes the pain over the bridge of the nose. That is known as anterior ethmoidal nerve syndrome or Sludger's neuralgia. One test is there which is known as Cottle test. It is used to confirm if the obstruction is in the nasal valve area. The patient is asked to pull his or her cheek laterally, and if the airway improves, it confirms that the obstruction is in the nasal valve area. So this is done in deviated nasal septum. Another important disease of the nose is the nasal polyps. Now, what are polyps? They are the non-neoplastic pedunculated masses. But if seen in less than 2 years of age, then meningocele should be suspected. We saw in some previous sessions that if a nasopharyngeal mass is present in infants, then encephalocele should be suspected. And if a nasal mass is seen between 2 to 10 years of age, then always you should suspect and rule out cystic fibrosis. Now, in the etiology of nasal polyps, one theory which you might have learnt in your physics, Bernoulli's phenomena, that is involved. Whenever air passes at speed, there is creation of a negative pressure which pulls the mucosa out, and the mucosa comes out as a polyp. This theory is being used to know the generation of polyps. Next is Carter-Jenner's syndrome, which is primary ciliary dyskinesia. Young's syndrome, that is hyperviscidosis. So these two syndromes, they are associated with nasal polyps. Now there are two types of nasal polyps. One is the enterochoanal polyp, also known as Killian's polyp, and ethmoidal polyp. In this table, we will see the difference between the two. So enterochoanal polyp, it is more common in children, while ethmoidal, it is more common in adults. Enterochoanal polyp has an infective etiology, while allergy is responsible for ethmoidal polyp. Enterochoanal polyp, they are usually solitary and unilateral. Ethmoidal polyps, they are multiple and bilateral. The enterochoanal polyp, it arises from the maxillary sinus near the ostium, while the ethmoidal polyp, it can arise from ethmoid sinus, uncinate process, or middle meatus. The enterochoanal polyp grows backwards towards the choana, while the ethmoidal polyps, they grow anteriorly. The size, the enterochoanal polyp has a typical trilobed structure with enteral, nasal, and choanal parts, while ethmoidal polyps, they look like small grape-like masses. Recurrence is very less common in enterochoanal polyp, while it is more common in ethmoidal polyp. The treatment is, in enterochoanal polyp, you have to do a polypectomy, endoscopic approach, or a Caldwell approach, external approach. In ethmoidal polyps also, you have to do the polypectomy. Initially external approaches were done, but nowadays functional endoscopic sinus surgery is done. Now we talk about CSF Rhinorrhoea. What is CSF Rhinorrhoea? CSF Rhinorrhoea is the escape of CSF from the nose because of some defect. Now the pathway of the leak can be from the anterior cranial fossa, which is via the frontal sinus, the ethmoid sinus, and the cribriform plate, or it can be from the middle cranial fossa, which comes out via the sphenoid sinus, mastoid air cells, middle ear eustachian tube, or it can be from the posterior cranial fossa, which comes out via the sphenoid sinus, mastoid air cells, middle ear, or the eustachian tube. So there is one sign, reservoir sign. Now similar sign we saw in acute mastoiditis. This is a different sign, though the name is same. After supine position, if the patient is made to sit up and neck flexed, there is sudden rush of the clear fluid from the nose. This confirms that the patient might be having CSF rhinorrhea. Another sign in CSF rhinorrhea is handkerchief test. What is this test? Whatever the fluid is coming from the nose, it is put over the handkerchief. Now if the stiffness of the handkerchief occurs, then it is not CSF, but it is due to the rhinitis, because mucus is present in nasal discharge but not in CSF. Third sign seen in CSF rhinorrhea is halo sign, also known as target sign, also known as double ring sign. Now it is seen in those cases in which the CSF is mixed with blood. So if we put over a handkerchief or some blotting paper, the central spot will be of the blood and the periphery will be occupied by the CSF. So that is known as halo sign. Now beta-2 transferrin, if it is found in the fluid, that it is a pathognomic of CSF rhinorrhea. So it is the most specific test for CSF rhinorrhea, beta-2 transferrin in CSF, most commonly asked in MCQs. CT cystonogram, it is used to localize the leak, and then the leak is repaired using multiple layers. From the mucosa, some muscle mass is kept and some fibrin glue is also used to close the seal. Now next is nasal bone fractures. So there are two types of nasal bone fractures. Class 1, also known as shibboleth fractures, a class 2 type of fractures known as Jarjave's fractures. So what is shibboleth fracture? When the blow is from the down, somebody hits from the down like this. So there will be the depressed nasal bone, but the nasal septum might not be involved. That is shibboleth fracture. What is Jarjave's fracture? That is a blow from the front, also known as open book fracture. The septum is also involved and septal fracture is also present in class 2. Then comes some fractures of the facial bones. Now fracture of the mandibular. Most common site of the fracture of mandibular is subcondylar region, can be asked as MCQ, followed by angle, the body and the symphysis of mandible. And subcondylar fracture is caused due to indirect force on the chin or the contralateral side. For example, a fracture of the subcondylar part of this side. So the force is either at the chin or the opposite side, which will cause the fracture of the subcondylar region of this side. Now, there are 3 types of named fractures: Leaford type 1, type 2, type 3. We can see the diagram of the Leaford type 1. Leaford type 1, also known as transverse fracture. The chances of infraorbital nerve damage are more in this type. Leaford 2, also known as pyramidal fracture. And Leaford type 3, also craniofacial disjunction. The fracture lines runs in such a way that the whole of the cranium, it is separated from the nose. Another fracture of the facial bone is the zygomatic fracture, also known as tripod fracture. Why tripod? Because the zygoma bone is situated here. It gets detached from the frontal bone, from the temporal bone and from this orbit. So this is known as a tripod fracture. It can be asked directly as MCQ. So this concludes our nose. Now we move on to the paranasal sinuses. Okay, so there are 4 paranasal sinuses, that is maxillary, ethmoid, sphenoid and frontal. Out of these 4, the maxillary and the ethmoid, they are present at birth, while the sphenoid and frontal, they develop later. So this can be asked as MCQ. Now the first radiological evidence of the maxillary sinus, it occurs at around 4 to 5 months of age. Of ethmoid at 1 year of age, then sphenoid at 4 years and finally frontal at 6 years of age. So up till 6 years, frontal sinus will not be seen in X-rays. Now sinus ventilation, it occurs during expiration. This is very important. The ventilation of the sinus occurs during expiration, not inspiration, and it is because of the production of eddies current at the Lyman nasi. There is one nasal cycle, which is the rhythmical mucosal congestion and decongestion. This is a normal phenomenon which occurs every 2.5 to 4 hours. The front of the nose, it can filter particles up to 3 micrometers, while the nasal mucosa, it traps particles as fine as 0.5 to 3 micrometers. Around 1 liter, that is 1000 ml of water, it is evaporated from the nasal mucosa in 24 hours. Okay, so some disorders of the smell, that is parosmia. The person interprets the odors incorrectly. This is seen in some cases of post-influenza and some intracranial tumors also. Now we talk about sinusitis, acute sinusitis. The sinuses involved are the most common maxillary, followed by frontal, ethmoid and sphenoid. Why maxillary sinus is involved more common? The reason is that the drainage of the sinus is at the higher level from the floor of the sinus. So secretions tend to accumulate in the sinus and chances of sinusitis are more. The most common organism, it is Streptococcus pneumonia, followed by H. influenza and Moraxella catarrhalis. Now maxillary sinusitis. The pain of the maxillary sinusitis, it radiates to the gums and teeth, aggravates on coughing and stooping. This is the characteristic of the pain of maxillary sinusitis. Likewise, in frontal sinusitis, it is known as office headache, because in the morning there is no headache. Now, as the day passes, the patient complains of headache in the evening. That is known as office headache. In ethmoid sinusitis, pain is felt over the nasal bridge, while in sphenoiditis, there is retroorbital pain and occipital headache. Now, what are the views, X-rays, which are used for a particular sinus? So, for maxillary sinus, Waters view is used. For frontal sinus, Caldwell's view is used. For ethmoids, Caldwell as well as basal view is used. And also for sphenoids, lateral view and basal view is used. Now, in sinusitis, many times nasal decongestant drops are prescribed to reduce the congestion of the sinuses. But A word of caution is that they should not be used for long time because the patient may develop what is known as rhinitis medicamentosa. It is the rebound congestion. That is, as soon as the patient stops these nasal decongestants, there is rebound congestion. So what is the treatment if at all rhinitis medicamentosa occur? Topical nasal steroid should be given and the use of the nasal decongestant should be discontinued. Now, fungal rhinosinusitis. There are 4 types of fungal rhinosinusitis. One is the chronic invasive fungal sinusitis. Another one is acute fulminant. Third one is allergic fungal rhinosinusitis. And fourth one is a fungal ball. We will talk each one individually. First is a chronic invasive fungal sinusitis. Aspergillus niger and flavus, they are the most common organisms to cause chronic invasive fungal rhinosinusitis, followed by mucor and sometimes rhizopus. Now, MRI is the investigation of choice, and treatment is long-term amphotericin B and itraconazole, that is the antifungal agents, they are given, and surgically whatever the tissue is there, it should be debrided. Another one is fungal ball. This is a disease in which there is a formation of a fungal ball, most commonly in the maxillary sinus. It can be removed endoscopically, and chances of recurrence are very rare in fungal ball. Third type of fungal rhinosinusitis, it is acute fulminant. Now, an important point is that it is seen in uncontrolled diabetics and immunocompromised patients. The most common organism involved is mucor, so it is also known as mucormycosis. The mucor is from the family Mucorales, Rhizopus oryza. This is an important point. This is asked as MCQ. Now, this fungus, it has a remarkable affinity to evade the blood vessels, and it leads to extensive endothelial damage and thrombosis. The fourth type of fungal rhinosinusitis, it is the allergic fungal rhinosinusitis, in which there is thick mucus with eosinophils and charcoal-laden crystals. Now, what are the complications of sinusitis? So, what are the complications of sinusitis? First is the osteomyelitis of the frontal bone, more common in long-standing sinusitis. So, if at all osteomyelitis occurs, it is more commonly seen in frontal bone. Now, there is one term, Pott's puffy tumor. It is not a tumor, it is actually a misnomer. What is it? It is a subperiosteal abscess subsequent to the frontal sinusitis caused by Staphylococcus aureus. Then another complication is the superior orbital fissure syndrome, which is the progressive paralysis of 3rd, 4th and 6th cranial nerves and deep orbital pain. It is subsequent and more commonly seen in sphenoiditis. Another complication is the orbital apex syndrome. Now, it is the superior orbital fissure syndrome along with the involvement of 2 more nerves, that is the optic nerve and the maxillary division of the 5th cranial nerve, that is trigeminal nerve. Another complication of sinusitis is that intracranial abscesses, subdural and frontal abscesses, they are more commonly seen. Mucoceles and pyoceles can occur as a complication. Now, point to be noted is that in mucoceles, they are most common in frontal sinus. It can be asked as MCQ, followed by ethmoid, maxillary and sphenoid sinuses. Now, some sino-nasal tumors. First is osteoma. It is the most common benign sino-nasal tumor. And the commonest site of osteoma is mandible. And commonest site, if asked in upper jaw, then it is the frontoethmoid area. Overall, it is mandible, but specifically if it is asked in the upper jaw, that is maxilla, so it is the frontoethmoid area. Another tumor is inverted papilloma, also known as Ringer's tumor. Why it is known as inverted? Because here the epithelium grows downwards inside into the stroma. So that's why it is known as inverted papilloma. It most commonly affects male, seen in the lateral nasal wall, and it requires the complete removal followed by the drilling of the bone. This is important for complete removal. Now, some malignant tumors. Squamous cell carcinoma is the most common, also known as nose picker's cancer, because it is seen more commonly in those people who continuously pick their nose with fingers, and it is also seen in those patients who are exposed to nickel. Another tumor malignant is the olfactory esthesioneuroblastoma. It is a type of neuroendocrine tumor. Then adenocarcinoma of ethmoid. Important point is that it is because of the wood dust exposure. And the commonest soft tissue sarcoma, it is rhabdomyosarcoma. So all these can be asked as multiple choice questions. With this, we conclude this session.